close big wounds. It's important because you get wounds under tension, you get traumatic wounds, you get wounds that for some reason, after, for example, you do a fasciotomy and you find that the wound after 48 hours is expanded, it's got enough laxity, but the edges are not well opposed. You need to be able to approximate those wounds really, really easily. So I'm going to teach you a few techniques. I'm going to teach you the importance of those techniques. I'm going to show you some tricks to help you if you struggle. So first things first, you need to do a layered closure for a few reasons. The first is you've got a potential space. In that potential space of any wound, seroma, which is like inflammatory exudate, blood can collect, and those are both mediums for infection. Infections are not good because they make patients unwell. Infections are not good because they will lead to longer inflammation phases of wound healing, which result in keloid scarring. That's right. So we don't want that, and also the wound won't heal. So neither of them are good. An infection is painful, requires washout and intervention. So we want to prevent that by perfecting the ability for fluid to collect. So you do a deep layer and then a superficial layer. It also takes off tension off the top layer, which means that the edges will be well opposed and more easily opposed. So we do layered closures for those reasons. I'm going to show you a few techniques to help your practice of wound closure and the way you would do it normally for the simplest of wounds. And then I'll show you some techniques for wounds that are under a lot of tension that at first glance may not close with just these simple techniques. So the first technique, which you would normally do, is the deep dermal. So for a wound like this, you need to bring the edges together because they're distracted slightly. If you're getting value, subscribe. If you want to do the mentorship program and you want to become a member to join our members only live and get one-to-one tuition, you can do that on our website, medsyncltd.com/resources. Click the link in the description, or indeed you can just become a member on YouTube, but you get less value, in my opinion, because you don't get the one-to-one face-to-face. So for the deep dermal, you go from deep to superficial. On the side closest to you, I'm using a dyed PDS suture, which I wouldn't do in a patient because the suture may be visible under the skin. And we'll talk about suture selection in wounds under tension as well, because that's also a part of making your life easier. And then on the opposite side, I'm going from superficial to deep. What you may have noticed is that I did not go vertically from deep to superficial and the superficial to deep. I went obliquely so that I had a lot more tissue grabbed by my suture. The next difference you'll notice is I'm going to tie this parallel. 1, 2. And then I'm going to continue. If this opened a little bit, here's a trick. I'm going to slip the knot. That means normally this suture needs to come here and this suture needs to go here. They need to alternate their position to make it a square knot. Because it's gapped, I'm going to slip the knot. So I'm going to go like this. I'm going to pull the suture through the loop. I'm going to pull just the short suture till the wound reapproximates. And then when it approximates, I'm going to pull the long one like this. And it's already closed really nicely. I'm happy. It's a deep dermal, so I'm going to cut this flush with the skin, so just above the knot. You can palm your scissors like this. Then take your fingers out and go like this. Normal. Welcome to premium membership. Pleasure to have you with us. We've also got the premium content, which you've got unlimited access to. But if you really want more and you want some one-to-one training, it's the same cost. Go to medsynclimited.com, click the description, cancel this membership and go to that one because it's the same cost but more value, including the YouTube videos. So you don't lose anything, you just gain and you get one-to-one training. How good is that? So I've gone from deep to superficial, pull it along the axis and not away. I don't want to rip it out. I'm pulling it along the axis which I've passed the suture. Leave a short end slightly longer than I typically would. And then rotate. So we're doing deep dermal sutures. I've gone from deep to superficial, superficial to deep. We're closing big wounds. Tie it 1, 2, grab the short end, pull it along the axis of the wound. Look how nicely that approximates. It's loosened a bit, so I'm going to slip the knot. Slip the knot means pull the suture through the loop. Don't pull the long end, just pull the short end like this, and boom. Now it's tight. I close with the other end. And as you can see, once you've placed a deep dermal, your epidermis should be pretty much well approximated. You want your knots to be well buried, so I'm just tucking that under. And the top tip really is to go obliquely rather than vertically. So I'm not going like this, I am going like this. Deep to superficial. Pull it along the axis. Let your needle stay within your view. Leave a long end or a longer end on the short end than I would normally. Look at the position. So I've gone from here. So this is a deep dermal suture. I'm going from deep to superficial, then superficial to deep. It's a really good suture for closing the deep space of a wound for wounds under tension. I'm taking my fingers out and I'm palming the needle holder. I'm going to go like this. I'm going to extend my wrist and then flex my wrist. Extend my wrist, then flex my wrist. This is the deep dermal suture from deep to superficial, then superficial to deep. And this is to close the deep space and to approximate a wound that's under tension, aka got a big gap in it. 1, 2, pull the short end, tie it. So this is a thing that can happen with the monofilament sutures. So if you've noticed, it's ripped out. Why is it ripped out? Well, in this case, because I've used the skin pad several times in the last few weeks, so it's well used. But this can happen in patients with thinner skin, so thinner dermis. So what's my solution? I'm going to take a bite somewhere where I haven't used it. Take a bigger bite. And the other option is to use a braided suture like Vicryl because it's got more grip. But I'm going to continue with this. Don't lose my stitch. Then I'm going to be careful I don't go somewhere that I've already. It happens in traumatic wounds. You can pull out just if you've got the solution to the problem. So you can use a braided suture and take a deeper, wider excursion by going even more obliquely than before. 1, 2, pull it through. I'm going to tighten it a bit by pulling the short end only. That's the slip knot. But typically you'll do a reef knot where you alternate their position, like so. And then I'm going to show you how I cut. So both sutures up. Yes, it does work, but the saphenous vein, so I'm going to cut this flush. So after doing a saphenous vein is subcutaneous. So in theory, you haven't cut or lost skin, so you can actually just stitch the skin with, it depends if you do staggered incisions for your saphenous vein harvest, like stab incisions, then you can just put some mattresses or interrupted. But again, to make it more robust, yeah, you could do some deep dermals first and then run your interrupted on top. But if you do a long incision for your saphenous vein harvest, then yeah, some deep dermals to just tack it together nicely and then run a subcuticular or interrupted or whatever your preference is. So that's the deep dermal. And then once your wound is like this, you can then do something on top like a subcuticular, because your edges are so well opposed. This is more opposed than these wounds, which I wouldn't even do a deep dermal on. So I would just go like this. The deep dermal is just a technique to close dead space, to approximate wounds. It's really good for wounds that are on mobile areas. So if I was to go like this on a stitch wound over my wrist joint, the wound is likely just to open. So once the top layer sutures come out, you want something longer lasting underneath that will withstand opposing forces. So I'm just doing a pull through subcuticular on top just to really make this wound bulletproof. So I started out in the apex there, taking superficial bites above my deep dermals, because if I take it within my deep dermals, my suture will cut the knot, because these are cutting or reverse cutting needles. So you go in opposite where you came out, as superficial as possible without cutting your other sutures. It should pull like this so that when you come to pull out the suture in a week's time, it comes out. This is the intradermal. Underneath it are the deep dermals. This is a small superficial bite than my deep dermal. Here, I think some of you would probably ask me, why would I do a pull-out subcuticular? Why is my end sticking out? Why didn't I bury it? You might do this in a child. So children often don't like scissors around their faces or limbs when they have their wound checks, if you have to come and take sutures out. So you may want to put a non-dissolvable suture in, but because you don't want to leave stitch marks. With a dissolvable, you're worried that the dissolvable will leave a stitch abscess. You want to control the wound tension a bit more. I'm going to show you how to correct the step like that, because we don't like that. That's not ideal. I'm going to put a stitch over that, but I'll show you. Talking about one word to use is pull out subcuticular. If you do blepharoplasty, the upper bleph and the lower bleph, you can do a pull out subcuticular that you remove in 5 days or so. And then you come out in the apex. And so in a child, if you see them in clinic in a week's time, you can just pull this suture out and it will unzip. Leave it long. And then if you wanted to hide this step in the skin, you simply take a little interrupted suture, go above, go a bit under here, take a bite, and bring your wound edges together, rather than taking the whole thing out, doing it all over again. If you're getting value, consider becoming a member. You don't get better just by watching, you have to practice. And the quickest way to practice is to practice with feedback. Medsync, medsyncltd.com/resources. The link is in the description. Become a member, get one-to-one tuition, access to these lives every week, but also the members only lives and the many members only videos on replay that we have to really harness your skills. So that was the deep dermal and an overlying suture. The next technique you need is how to approximate a wound like this. Let's not do that first. Let's keep you in suspense. Another technique you can use for a wound that's gaping a little bit, maybe like this, where you want to evert the wound edge because under a little bit of tension, but not enough for you to want to put a deep dermal in. You can use a variation of the horizontal mattress. So that is the locking horizontal mattress. So the locking horizontal mattress works like this. Watch my techniques for needle reversal. I go like this, I'm like this, I turn it over, I go like this, mount it where I want it, I take my fingers out and then rotate it, and it's ready to go into reverse. So hold the needle upside down, mount it where you want it, and then take your fingers out of the needle holder and rotate it. And then we go backwards to where we came from. And then I use my thenar eminence and my hand over here. I push and it unlocks the ratchet. So I go like this. For those that do vascular general surgery will know this probably. You just push up with this, down with this, and you're good to go. So this is the horizontal mattress. to make it a locking horizontal mattress so that this loop doesn't go into the skin and distributes tension a bit more evenly, you go through the loop. It's not a pretty stitch, but it works well to take off some of the tension off the wound edges. And then tie 1, 2. Ah, that's another trick. I'm not going to give you that trick just yet. Up together and then cut. That's the locking horizontal mattress, and I'll do that again. I'll show you another way to reverse the needle. Why is that important? Because you just want to be quick and not waste time, really. So we go across, put it through, mount it straight away, put it through, leave a short end. We put the body of the needle holder on the side, unlock the ratchet a little bit, but keep the needle within the needle holder. And we just rotate like so, and we go straight across. Rather than spending a long time up in the air, dropping the needle, picking it back up, going like this, like this, like this, like this, like this. Just do one quick maneuver. So either you hold it upside down and mount it and then palm it, or you just swivel it around. The choice is yours. Or you do it your way, if that works for you. Make the loop, pass it through the loop, and we go. Again, for members, there's the members only content, which is available on YouTube from our website, medsynclathmanlimited.com. You get one-to-one training. You can access the members only lives every week on here as well. Watch it unlimited on replay. You get access to our exam and interview based content, clinical cases and images that YouTube will not allow us to post without censoring. So our website just has so much more. And also the premium videos are also available there. So we've done the deep dermal and the subcuticular on top. This locking mattress is where you've got a wound a bit more agape than, than a skin edge like this. So it's together, you don't want to put it on top, you want to take something that's gonna take off a bit more tension without the suture burying in the skin, and a locking horizontal mattress works well for that. Now we come into the final, the big boss. Something like that, a proper wound and the proper tension. It will close, but it just needs a bit of help. So the procedure is gonna be, we need to do deep dermals inside, but it's gonna be hard work, obviously. So rather than embarrass myself and let my sutures all tear out, I'm gonna work smart, I'm not gonna work hard. I'm gonna work from the outside in to the points of least tension to the points of most tension. I'm gonna go from here to here, here to here, here to here, here to here. By that time, this wound will be relatively well approximated, and just put one deep dermal in here. The second thing I'm gonna do, which is actually the first thing I'm gonna do, is I'm gonna take off the tension at the very start. How am I gonna do that? I'm going to do an interrupted suture in the middle. But I'm gonna do a maneuver such as a bit like hand tying. So I'm gonna go like this. I'm gonna go 1, 2, pull the suture down till the wound closes. It won't stay, so I'm gonna get my index finger and go under. There's one loop there. I'm gonna lay the short suture across it like a cross and squeeze the cross. I'm gonna go under the short and bring the short suture through the loop. Whilst I did that, I was squeezing this really tightly because that's keeping the wound closed. Now I'm gonna transfer the tension that I'm squeezing this with into the suture by pulling this really hard. See how the skin pads lift off? I'm pulling it really hard. That keeps the wound closed. If I drop the long suture, it stays closed. Now pulling the long suture tight and the wound stays closed. Now you might ask, why can't I just leave it like that? Because there's still the dead space underneath. So when the suture comes out, it will just ping open, no doubt. Let me show you again. I'm gonna do one more either side. And then we can put the deep dermals in between and then cut out these sutures or close the rest with interrupted sutures. So let's zoom in. Let me get rid of these sutures so it's a bit clearer. And we can zoom in and you can get all the value out of this little workshop. If you're getting value, like, comment, leave a little prizey thing. 1, 2, if you really want to upgrade your skills, just subscribe or become a member of the website for the same price, but more benefits. Index finger underneath, suture on top. Press the cross. squeeze it really firmly. Go under the loop, pull the short suture through, pull the short suture really firmly, keep the wound closed once you're happy. If you're not happy, you pull it harder, it will close more. Pull the long suture and tie. We can't leave it like that because there's still the dead space underneath. Like, subscribe, become a member of the website, medsyncltd.com/resources. The link is in the description. So we're going from just putting in some tension alleviating sutures so that we put in deep dermals in between and we don't have to work so hard. Other things we can do, we can just slide the suture across like this. It locks it, not like this, got under more tension. So we, just like that, it opens. I'm going to do a slip knot by pulling the short suture through. Now it's closed. I'm going to pull this one. That works for that because it's already taken off half the tension. It wouldn't work for that. These sutures will come out and then we can do a subcuticular on top after we place the deep dermals. So we're going to do the deep dermal suture now. I'm going to use a PDS so you can see it really nicely. Again, in real life, I wouldn't use a dyed suture because you can often see it under the skin, and this PDS is going to be there for about 3 months. So from deep to superficial, pull it, mount it straight away, take your fingers out, palmed, fingers are not in the holes. Go from superficial to deep, also at an angle. Push it, push this skin down so the needle comes above, and then you can grab the body of the needle, not the tip, the body, and pull. And then we tie it parallel, 1, 2, boom. Look how well that closes. Boom, and boom. Once you've gone around the needle holder, just commit to the tying because you're not gonna undo it. See, you wouldn't even know. I'm gonna put one in between there. It just makes your life so much easier. If you're getting value, press like. If you're still watching because you've been watching the whole time, press like. Let the algorithm know. Let the algorithm know that you're getting value. Don't be shy. Just press like if you're still watching. If you don't like, tell me why. If you have any questions, pop them in the chat. Let me know your thoughts. Fingers out. And rotate. Go above the skin so that's easy to mount. Grab the body, not the very tip. So I'm going to zoom in and just talk about the anatomy of this needle. We have the point, the body, and the swage. The swage is where the suture attaches. The body, you mount it 2/3 from the tip, 2/3 is here. You never grab the point, you only ever grab the body. So when I go like this, you may not be able to see it from the distance that I was at, but it's like this. I grab the body, not the tip. You go 1, 2, tie it parallel. And you see, by putting those tension alleviating sutures either side with that technique I just taught you, it really makes closing really easy. It was almost easier to close that with deep dermals than it was to close that. And then I'm going to cut those sutures out once I finish this, and you can see the results. Remember, I go obliquely for the deep dermal, I don't go vertically. It gets more bite. Mount on the tip, not mount the body, not the tip. Mount it straight away. So if you see, the tip is right here. Tip is there, I'm past it. Mount the body, put it through. I'm aiming to get another suture out of this, so I'm being trying to be conservative with my use at this point so that the last suture is easier. Again, if you're getting value and you've been watching consistently, like it, press like. If you really want to upgrade your skills and get one-to-one with a surgeon, medsinkltd.com/resources. You can watch all the members only content, which is far better than this stuff. And there's more of it. And we do weekly lives, and you also get a monthly one-to-one for every month you remember. Same price as the YouTube membership, so actually better value for money. And you can quit anytime. So deep, superficial, superficial to deep. Go obliquely. Let your needle come above the skin so it's easy to grab. Grab the body, not the tip. Pull it through. Pull it a little bit so the short end is short. 1, 2. And you see how well approximated that wound is, if I say so myself. And then you cut flush. So now is going to be the test of how things hold once I take out those tension alleviating sutures. I hope you're excited to see if it worked, as I am. And as you can see, it did. Look at that. And then often, one of the things people do that you need to stop doing is this, testing your closure. Don't do it. If it's not going to work, it won't work. Going like this and testing your stitching, not necessary. Just leave it and put your next layer of sutures in. So my last layer of sutures is going to be a continuous suture. Why would I go for continuous suture? So often, these deep dark holes that you stitch up are a bit bleedy and oozy. So a continuous suture can also be hemostatic for any kind of veins that decide to open up later after the anesthetic or the adrenaline has worn off. So I often like to put a subcuticular or a continuous suture on top. If it's a clean wound, I'll do a subcuticular because it means no stitch marks on the outside. Nothing has to come out. But let's say it's a traumatic wound, traumatic long wound, rather than do interrupted and have lots of stitches to cut out, I might just do a continuous suture. That's what I'm going to do here. Again, it's hemostatic, it's quick, and it's easy. I'm going to try and be conservative because I've taken the choice to use a short piece of suture that I have left already, which I might regret at the end when I'm tying my knots, but you live and you learn. 90 degrees. You can go across in 1 because my edges are well opposed. I've mounted it straight away, so I can just keep on suturing. Grab the body, mount 2/3, and pull. I'm going to go a bit bigger on the far side because I think the bite is slightly too close on that bit. People always ask, how far do you need to take your bites? Just make it look pretty, as pretty as possible. So try and make it evenly spaced and go straight across rather than going obliquely. It will lie obliquely. You don't need to make it by stitching obliquely. If you stitch obliquely, it will stitch straight, which is also fine. But typically, you just go straight across. Go through, grab the body. Don't go through the loop, go outside the loop, mount it straight away, and pull. As you can see, my suture is getting shorter and shorter, so I could be getting nervous, but I know that one way or another I'll find a solution to my problem of tying, just to prove a point. So you have to now keep that and pretend it's a single suture. Grab the loop and pull it through. Catastrophic. It's all right. Let's go to the very end. I'm using the needle, risking my life. You just want to see me if I can close it. So one thing I can do is pull my suture down. Haha, you thought I didn't know what I was doing. Like a corset. have more length. And then I'm going to do 1 knot. And then I'm going to go 1 knot. So, like so. I'm going to do a slip knot to tighten it again. And then if this is ever too big, you can make the exchange to a fine tipped artery clip to pull it through, because they're slightly smaller than a needle holder, you see. So if you were impressed by the fact that I was able to tie that, like the video, and that's what you call using every millimeter of your suture. So if you, in summary, closing wounds under tension, deep dermal, and then whatever suture you want on top. To help reduce the distraction of the wound, put a tension alleviating suture across the wound. You can hand tie a little bit, that maneuver I showed you where you laid the suture across your finger, long end across, the short end across it, press it, bring the loop through, and then tie it. You can do slip knots to retension it. You can do a locking knot by sliding the short end towards the long to help alleviate the tension, and then put deep dermals in between. Start from the outside and work towards the middle. It's also another technique. And then the continuous suture on top is fast, it's easy, it's a bit hemostatic for the bleeding dermal edges, and distribute tension reasonably evenly. Use a braided suture if it's under a lot of tension that you're going to struggle, but a monofilament's fine, and use a long-lasting dissolvable suture for your deeper sutures. So that can be monocryl, PDS, or Vicryl. If you want more, some one-to-one training with a surgeon, medsyncltd.com. That's medsyncltd.com/resources. Link is in the description. One-to-one training, which is the best way to progress quickly. And weekly members only live and members only content. On that note, we'll see you next week. Goodbye.